Hi everyone, today we're going to be talking about some endocrine diseases. And the first one I wanted to cover is the diseases of the anterior pituitary. This is basically, if you remember where the pituitary gland is, this is basically an excess of growth hormone, and it's usually from a pituitary tumor. It leads to gigantism in children and acromegaly in adults. Acromegaly, and if you think about it, gigantism, this is growth hormone, so it causes us to grow. And in kids just get taller and their bones get thicker because their growth plates aren't closed. But in adults where we have our growth plates that are closed, we get this acromegaly. And it causes a thickening of our bones. When we look at our patients, this is a lady that had a pituitary tumor, and you can see her in her young days how she has very refined facial features. And as the tumor starts growing, we can see that she has thickening of her facial features until they're very coarse looking. The other thing that we see with patients with acromegaly is enlargement of the hands and feet. They actually get very elongated fingers. They're going to have clubbing of their fingers. They're, again, like I said, they have that thickening and enlargement of their forehead, nose, mouth, and their tongue actually gets large. And sometimes if the tumor is really big, their tongue actually doesn't fit in their mouth. They're going to have some thick, leathery skin. And one of the big problems with acromegaly, and the reason that we see patients with it, is that they develop cardiac diseases. They're going to have some cardiomegaly because it not only works on the bones, but it's going to work on our organs as well. So their hearts get really big. They're going to develop some diabetes, and they have some visual changes. Management of this is basically the treatment or removal of pituitary tumor. We can do surgery, radiation, or drugs. And we'll talk more about a transsphenoid hypophysiectomy in class. Some other things that we're going to do is we're going to screen and treat them for diabetes. They're going to be screened and treated for cardiovascular disease. And one of the big things with this is the emotional and psychological support. Because if you look at it, this is a very pretty young lady. And now we have this very thickened looking person. And emotionally, this can be very devastating for our patients. Looking at the posterior pituitary, one thing we're going to see, and we talked about this before, is SIADH, or Syndrome of Inappropriate Antidiuretic Hormone. And what we see with SIADH is where there's too much antidiuretic hormone released. And this result, and if you remember from anatomy and physiology, antidiuretic hormone is what saves our water. So our patients, they have syndrome of inappropriate antidiuretic hormone where they saving the water. They're not going to save the sodium, so we're going to not see the signs and symptoms the same as fluid overload. Some of them are the same, and some of them are we won't see at all. But you can see by my picture, it's the ocean. They're full of water. So our clinical manifestations, we're going to see some of those signs and symptoms. We're going to see increase in vascular volume. So they're going to be hypertensive. They're going to have the bounding pulse. They're going to have the JVD. The one thing that we don't see so much in SIADH is edema. It stays in the intravascular volume. The thing is we save water without saving sodium. So we're going to see a dilutional hyponatremia. So they're going to be very hyponatremic. So again, we need to know the signs and symptoms of hyponatremia. We're also going to see a hypoosmolality. So rather than having that serum osmolality at a 275 to 295, it's actually going to be significantly less. I had a patient the one time that came in with SIADH, and serum osmolality was, I believe it was 200 or 210. Sodium, of course, was in the hundreds, and so Just, you can see that. They're going to have a low urine output. In severe SIADH, we're going to have cerebral edema, confusion, seizure, and coma. The serum osmolality, like I said, is going to be low. The urine osmolality, and while we don't need to know the numbers about this, we do need to know that the urine osmo is going to be really high. We're not getting rid of water, we're getting rid of all the solutes. So collaboratively, they're going to treat the underlying cause, which whatever caused it. It can be from a head injury, it can be from small cell lung cancer, which actually makes its own antidiuretic hormone. It can be trauma, it can be narcotics. There's a wide variety. So we need to treat that underlying cause. Our patients may be on a fluid restriction. And typically it's 800 to a liter per day. So our patients are going to have problems with dry mouth. They're going to need daily weights, I's and O's, sodium replacement if it's really severe. The lady that I had that was, I believe the sodium was like 106, we actually gave a hypertonic 3% saline to. And that in itself causes problems because while we're giving them lots of saline or giving them lots of sodium, we need to be watching for more fluid overload. We're going to need to be doing our assessments, seizure precautions. The head of the bed needs to be below 30 degrees. This is going to slow down the antidiuretic hormone release. The other one that we see is diabetes insipidus. So while SIADH is too much antidiuretic hormone, diabetes insipidus is not enough antidiuretic hormone. So our patients are going to be dry. They're going to be in a fluid volume deficit. So thinking again, what are those signs and symptoms that we would see with a fluid volume deficit? Again, there's a picture of sand dunes because our patients are extremely dry. So what are we going to see? We're going to see polydipsia, an increase in thirst, polyuria, an increase in urine output. And these guys, it's not unusual for them to put out 20 liters a day. We're going to see a low urine osmolality and a high serum osmolality. So rather than being less than 275, they're going to be on the high side or 295 or greater. They're going to have weakness, fatigue, constipation, hypotension, and in severe cases, they're actually going to be in shock. Diagnosis is going to be a water deprivation test where we do a weight and vital signs, and then we withhold water for 8 to 16 hours. What we're going to see is our patient's going to lose a lot of weight, and a lot of times they never make it to 16 hours. Then we give them vasopressin, which is an antidiuretic hormone. It's very synthetic, and we're going to be looking at, does that urine osmolality increase? Collaborative care, we're going to need to maintain fluid and electrolyte balances. We want to give them D5 in water, because if you remember, even though D5 in water is an isotonic solution, when it gets into the bloodstream, it dissociates. So we have a little bit of dextrose and we have a lot of water, which is what these patients need. We need to replace the volume. They're going to be on intravenous or oral desmopressin or vasopressin, which is a synthetic antidiuretic hormone. Thiazide diuretics is going to slow down filtration and allow water to be reabsorbed. And again, we need to monitor daily weights and I's and O's. Some of the other problems that we see in the endocrine system is hyperthyroidism. Hyperthyroidism is an excess of thyroid hormone. Now think about, what does the thyroid hormone do? It regulates our metabolism, it regulates our oxygen consumption, it regulates our fat metabolism. So when we have too much, it also regulates our cardiac function, and there's a wide variety of things it does. When we have too much or a hyperthyroidism, our patients are basically zooming and booming. And if you look at this patient here, look at how thin he is. Look at his eyes. He looks like he's scared. And this is called exophthalmos. It's where their eyes literally bulge out of their head. Diagnostically, we're going to look at the TSH. TSH comes from the anterior pituitary. It tells the thyroid to do its job. So when we look at our TSH levels are going to be very low. Our T4s, which come from the thyroid, are going to be very high. So collaborative management is going to be to block the thyroid. We can use medications, some antithyroid drugs. This inhibits the synthesis of thyroid hormones. We can use iodine. We especially like to use iodine because it blocks T3 and T4, and especially for those patients that are going to need surgery. It's going to decrease the vascularity of the thyroid. Beta-adrenergic blockers or beta blockers to relieve those cardiac symptoms. They may need some radioactive iodine therapy. This is going to damage or destroy the thyroid. It can take up to 2 to 3 months. And with effective treatment, our patient is then going to be hypothyroid. Some of our nursing diagnoses, we would see activity intolerance, imbalanced nutrition, and we might need some cardiac monitoring, and they're definitely going to need artificial tears. With hypothyroidism, if you're zooming and booming with hyperthyroidism, you're going to be slow and sloth-like with hypothyroidism. You cannot produce any thyroid hormone. So our clinical manifestations, they're going to be fatigue, lethargic, impaired memory, low cardiac output, anemic, cold intolerance, hair loss, dry, flaky skin and nails, and they're going to have weight gain. Some of the complications of hypothyroidism is a myxedema coma. This is lethargy, which eventually goes into a coma. The client's going to be hypothermic, hypotensive, bradypneic, and these people need some thyroid replacement. So diagnostically, we're going to see a high TSH, the anterior pituitary saying, hey, spit out some T4, we're dying here, and the thyroid says nope. So the T4 is going to be very low. So collaboratively, our patient is going to need some levothyroxine or some type of thyroid replacement. The dose is adjusted by the thyroid stimulating hormone. We're going to teach our patients to look for signs and symptoms of hyperthyroidism. They take it the same day on an empty stomach, and they're going to have some weight loss with this. But that's what we want. They gained weight because of the hypothyroidism, so we want them to lose some weight. Last one, hyperparathyroidism. This is a patient that has increased the parathyroid hormone. The result of a benign tumor. The results in increase in calcium. So our signs and symptoms are going to be all of those of hypercalcemia. Weakness, loss of appetite, constipation, kidney stones. Collaboratively, our surgeon is going to do a parathyroidectomy and transplant normal parathyroid tissue to the forearm or the sternocleidomastoid that's going to allow for some calcium regulation. We're going to need to prevent some osteoporosis or holey bones, and they're going to need medications to prevent bone resorption. Hypoparathyroidism, we see, is an inadequate parathyroid hormone, and this is due typically to the unintentional removal of the parathyroid glands during surgery. What we're going to see is those signs and symptoms of hypocalcemia, so chavostics, trousseaus, cardiac dysrhythmias, numbness and tingling of the lips, hands, and feet, muscle cramps, laryngospasms. The treatment is going to be intravenous calcium. We're going to need some EKG monitoring, some respiratory monitoring, and they're going to need to be on calcium replacements for the rest of their life. And that concludes the first part of endocrine system. Thanks and have a great day.